Hi, hopefully you're having a good day. So the girls have asked me to do a talk about non-invasive ventilation in patients with motor neuron disease, and I have one slide on oxygen as well, which is just very brief. So what is non-invasive ventilation? Hopefully all of you have seen it or know what it is. It's a similar machine to what you would use if you were having a patient with sleep apnea, except we use different level, different machine with different setup, which makes patients a bit easier to manage their symptoms. We all do know that patients with motor neuron disease will die from respiratory failure. Sometimes patients with motor neuron disease, their first symptoms might be presentation of respiratory onset. And what happens is that respiratory muscles weaken, which makes it really hard for a patient to breathe, and therefore, their breath is much less, therefore their oxygen taking it is significantly less, and then they're finding it difficult to breathe out to get rid of their carbon dioxide. As that happens, they get shortness of breath. For some patients, that may happen earlier in their disease process, and for some patients may present at the end stage of their disease process. We use bi-level ventilation, and it is a non-invasive ventilation. It has two distinct sets of pressures. One pressure is a inspiratory pressure, so when a patient takes a breath, which is always a bit higher because it pushes air in. And then you've got expiratory pressure, which is they're taking a breath out, which is always less. And we find that when we do these two sets of pressures, it makes it much easier to patients to manage their breathing. For some patients, they might first start on CPAP machine itself, which delivers constant one pressure, and then they might transition to the non-invasive ventilation itself. And I guess the important thing is to manage when you're introducing any new therapy for a patient or suggesting anything, they need to recognise that non-invasive ventilation is a way of managing their symptoms, but it's not going to stop their underlying disease continue to progress. So at some point in time, even non-invasive ventilation is not going to suffice just to managing their shortness of breath, so you might need to manage with different medications, patches, or whatever it is, how they want to manage their end of life, or death rather. Some of the symptoms that patients may have, they might indicate that they might be getting in trouble from respiratory failure. Point of view are there, but there's lots of others that I may have not put there. And each person is different. You might have, we've had patients that they're walking, talking, but the first thing they present to us is significant respiratory failure. They're already short of breath. They can't walk much of a distance. They've got, they've lost most of their muscle bulk on their chest. And if you manage those patients with non-invasive ventilation, we do know that non-invasive ventilation can double patients' life expectancy. And for some patients, it gives them years or what they perceive it to be quality of life for themselves. It's important to question these patients from the beginning. So when we see our patients in our clinic, we have obviously multidisciplinary clinic, and we have respiratory physician, but a huge part of my role is when you're having a regular contact with them over the phone is to question, are they developing any new symptoms from a respiratory point of view, or whatever it may be that you need to manage that maybe sooner in between the clinics as well. Because we do know the sooner you instigate non-invasive ventilation, that it does give them better quality of life. Obviously, they're having a better sleep. And if you're having a better sleep, we all know, especially if you have little children, you wake up during the night frequently because your sleep is fragmented, and then during the day, you're just cranky. And the same goes for our patients, plus it limits what they can do. Because we need to kind of think the patients with motor neuron disease, whatever they do during the day is like they're running marathons, because, their muscles are so weakened, and then if you put respiratory failure on top of that, it just makes it so much harder for them to manage. So the goal of non-invasive ventilation is obviously to manage their symptoms of shortness of breath, to give them hopefully better quality of life, improve their oxygen, their breath, so they get more oxygen and get rid of their carbon dioxide, controls their symptoms of shortness of breath, and hopefully improves their quality of life as well. And at some point in time, patients might turn to you and say, look, do you know what? It is providing symptom relief, but I'm not finding any quality in life that I have, and I need to stop using my non-invasive ventilation, and you need to approach that, how you're going to address that. Other issues that you might need to consider, and we tend to consider quite early in our clinic, is that even from the point of view when you first see patients, these are things that you need to, bring up, so that at some point in time, if the non-invasive ventilation is something you need to think actively about, it doesn't come like, lightning from the sky, that you've never talked about it, they're scared of it. And you need to talk about, okay, well, we're going to start non-invasive ventilation. Where do you see this therapy going to? Do you have endpoint? At what point in time would you see yourself? And they don't need to give you the answers. What you're trying to do is, I guess, trigger their thought processes. So at some point in time, they have an idea what their endpoint would be or where they would perceive the therapy to stop. And doesn't mean they have to strictly adhere to it. You know, you might have a patient that might say, well, I've achieved A, B, C, D, I will stop my therapy. But they might go, actually, I'm quite still having reasonable quality of life. I'll continue to use the therapy. But you need to consider those things and discuss them with them on an ongoing basis. So every time you would see a patient in the community or in a hospital, wherever there is, you need to revisit to make sure the therapy is working for them, that it's appropriate way to manage their symptoms. And we always talk about good death, and I don't necessarily term it good death to my patients, but I guess it's a good death in a sense where the patients will see where they would want to take the therapy to, and at what point in time, how would we manage stopping the non-invasive ventilation. And hopefully you'll have palliative care team involved so that you can transition patients to that good death as such. And huge part of patients coming and, you know, having non-invasive ventilation or any therapies that we've heard today is involving their carers. Because sometimes you need to be mindful the person might have cognitive impairment. Is non-invasive ventilation the best thing for that person? Would they want it? And also if they've got hand function difficulties, you need to make sure that the carer is quite comfortable with notion of putting a mask on their face, managing it. You need to think about things as, you know, patients in the bed at night time. If the carer is sleeping in a different room, how they're going to manage it, they need to take the mask off, how they're going to manage that. And managing all those social situations, interaction is very important to consider as well. It's not just saying, you need this, take it home and deal with it. So you need to consider lots of things in their everyday life and function. So what we tend to do with our clinic is when we start non-invasive ventilation, we bring patients into the hospital for 2 to 3 days. And then we manage that so that they have enough education and support in regards to that. And you slowly start introducing it maybe 2 hours a day, and then slowly build up to what level they feel like they need to do it. And you're continuously monitoring and observing patients. I put a slide there just because we use overnight oximetry to show us how non-invasive ventilation works really well. The slide on the right is before non-invasive ventilation, and after we've instituted non-invasive ventilation, what the overnight oximetry looks like, and hopefully their symptoms improved. And that's one of the papers that was published about benefits of non-invasive ventilation in 2006, which started the trend for patients. And oxygen. I guess it's a very individualised thing. At what point in time would you consider oxygen if patient is not able to tolerate non-invasive ventilation and they're having some symptoms? You'd have to, you know, consider with the respiratory physician if the oxygen saturations are 88% or less on room air, or their blood gases are 55%, less than 55. So what you need to do, I guess, is have an individualised look at the patient, and sometimes even just giving them oxygen for comfort is better than, you know, I guess not managing those symptoms as well. But you'd always have to have a palliative care input. I always advocate palliative care from day of diagnosis to the day of death. And I think, you know, working as a team, it's a great way of managing that. Thank you.